Hi, everyone. Thanks for coming. So welcome to our seminar on stakeholder engagement for digital health research. And so the plan for today is to have three panelists. We have Gloria Nyankima, Anobel Odisho, and Alexis Beatty. And each of the panelists are going to talk on the topic for about 10-ish minutes. And then I've prepped some questions for them, but we'll also be taking audience questions. So if you have questions, please go ahead and put it in the Q&A box. So we're going to start off with Alexis, followed by Anobel, and then Gloria. And then let's see. So I'm going to do some quick introductions for each one. Alexis is an associate professor in the Department of Epidemiology and Biostatistics and a cardiologist in the Department of Medicine. She studies innovative delivery models for cardiovascular disease care to improve outcomes and reduce disparities. Anobel is an associate professor of urology, and his interests include incorporating novel techniques to improve care delivery using interactive data visualizations to inform patients and increase engagement, and health services research to understand trends and patterns in kidney cancer care delivery. And then Gloria is a biomedical engineer and digital health policy advisor in the policy team of the Digital Health Center of Excellence at the FDA. And she's been working at the FDA since 2019, where she has led projects implementing digital health policy for constituents, both internal and external to the FDA. So with that, Alexis, why don't you kick it off?
Thanks, Jean. I'm going to go ahead and start sharing my presentation here. My piece in this seminar today is to talk about patient engagement in digital health research. And I'll start out just by talking about why someone might want to engage patients in research. And we believe that considering the lived experience of patients makes the research more accessible, patient-centered, relevant, and ultimately useful in practice. And when I think about engagement, whether it's with patients or with other stakeholders, I think about it using this framework. There are many frameworks out there. Some of them chunk things into even smaller chunks, but I think that you can basically break them down into consultation, involvement, and partnership or shared leadership. And in thinking about these levels of engagement, you can often start with thinking about it as consultation, so consulting the stakeholders about their opinions and perspectives. And an example of that could even be something as simple as a survey of patient preferences. Kind of the next level of engagement is involvement. And this is where stakeholders play a larger role in the design and execution of the research. And so this may be something like a patient advisory board that helps with designing recruitment materials. And then the more involved level of engagement is partnership or shared leadership. And within this, the stakeholders are part of the study leadership and part of driving the research forward. And so this may be, an example of this may be where stakeholders and researchers jointly formulate a research question and seek funding. And as an example of these different levels of engagement, I'm going to talk about a study that we're working on right now. That's a PCORI-funded study that's looking at the comparative effectiveness of in-person and telehealth cardiac rehabilitation. And we call the study the McNair study. And I'll get into a little bit more about why we call it the McNair study in a few minutes. But within this study, we actually included patients in our grant writing process. So we had two patient partners that were part of our leadership team as we were writing the grant. And we actually convened a patient advisory board while we were writing the grant to help us with formulating the aims and ultimately designing the study. And the aims of our study, the first one is to tailor a telehealth cardiac rehab program to diverse populations at 4 sites. The second aim is to do a randomized trial comparing telehealth cardiac rehab to in-person cardiac rehab, and includes both sort of objectively measured and patient-reported outcomes. And then the third aim is to understand the factors influencing the implementation of and participation in telehealth cardiac rehabilitation. And as we're doing this project, we are doing all 3 of these different levels of engagement. So we do have patient and caregiver questionnaires that we administer to understand people's preferences and attitudes and beliefs. And we are directly involving patients and caregivers in our advisory board. We're also doing extensive involvement of patients and caregivers in our first aim, which is the aim that's tailoring materials to diverse populations. And so we have patients and caregivers participating in iterative human-centered design. And then the other element of this, which I alluded to earlier, is that 2 patients are actually part of our study leadership team. And these patients contributed to our grant application. They actually lead our patient advisory board meetings. And so we're more observers in these patient advisory board meetings, and the patients lead them. And then they also attend our study leadership team meetings to provide the patient perspective kind of at every level of the operation of the study. And one of my favorite examples of how this patient engagement has been influencing the study is in the development of the study name. So often, we do these research study names that are like these, fun acronyms that are built off of some, version of the official title of the study that you submit to, NIH or PCORI or whomever. But our patient partners actually said, no, you should name the study after a patient. And at first I was like, I don't know about this idea. But we actually ended up putting it to a vote of our patient advisory board and investigators. And we voted to name the study after one of our patient partners, Tricia McNair. And Tricia, I think, explained to me exactly why doing something like this has the potential to be powerful. And Tricia said that cardiac rehab saved my life, and I want to represent the many women and people of color who have limited access to cardiac rehab. And so it has actually become part of our recruiting tactics to include Tricia and her voice in thinking about how we're going to recruit patients and encourage them to participate in our study. And so we've developed a recruitment video, and this was done largely by one of my team members who I think is listening today, Ray. And the video goes through, what is cardiac rehab and why might someone want to participate? And it includes a testimonial from Tricia as to why she's involved with the study and why she thinks that this is important. And so this idea that I wouldn't have thought about, which is naming the study after a patient, has kind of given, in some ways, the study a North Star for how we're communicating the study to participants. And then, in addition to that involvement, we also involve patients and caregivers in human-centered design. And human-centered design is often talked about in 4 phases: discover, define, develop, and deliver. And it's an iterative process. And so some of this involves interviewing with patients. Some of this involves creating materials for the patients and then getting their feedback on them. And then some of it involves revising those materials and getting continued feedback on them. And so we started out with 3 sessions where we looked at a user journey and some scripts and evaluated the technology that we're going to use in our telehealth cardiac rehabilitation program. And then we also have have gotten patient feedback on the recruitment materials and the questionnaires. We have one session planned, which we may or may not use for review of the iterative revisions to study materials. And then we are actually going to have 2 sessions that are basically a dry run of the whole study, where people mock participate in the study and we get their feedback on the experience of the study participant. I just want to point out one big thing that has come back to us from this process with the human-centered design. So we had initially had this thing that we call a patient journey map, where we had some elements that we were considering to be required and some elements that we were considering to be optional. And in consultation with our patient partners and with our human-centered design sessions, we've basically changed the framing of all of these potentially optional elements as available elements, because they're things that people felt strongly needed to be included and should have sort of a stronger push toward them than just considering them to be optional. And so many of these available elements are things like other telehealth sessions with nutritionists or pharmacists. And the other part that people feel really strongly about is having the opportunity to interact with other people going through the experience through group telehealth sessions. In the interest of time, I'm going to skip through a couple of the examples here and talk about the way that we analyze some of the data and the feedback that we get back from participants. And so we don't do like grounded theory qualitative analysis of what the participants give us in terms of feedback, but we do a rapid template analysis using pre-existing theoretical constructs. One of the theories that we use and that we draw constructs from is this one called the Unified Theory of Acceptance and Use of Technology, which posits that there are these 7 factors that influence your intention to use some sort of technology, which is ultimately the strongest predictor of use of the technology. And so when we're analyzing the responses that we get from participants, we do a rapid analysis that kind of puts things into these buckets and helps us understand and contextualize the information and the feedback that we're getting from participants so that we're thinking about it in a structured way. Our next steps in this process are to complete human-centered design at all 4 sites, and we're planning to begin our randomized trial in July 2023. And we plan to continue documenting the impact of the patient and caregiver engagement and ultimately describe it in a manuscript. And I think our takeaways are that there is a spectrum of engagement here, but that engaging patients in research can help to make the research more accessible, patient-centered, relevant, and useful. And I'd like to acknowledge our wonderful study team, including our team here at UCSF, especially Elisa, Ray, and Joan, who have done a lot to get this study where it is today. Thanks.
Excellent. Then I guess I'm up. So my name is Anobel. I'm one of the urologic oncologists, and I also lead the virtual care programs at CDRH, Center for Digital Health Innovation. And I'm going to focus a little bit about how to engage providers and staff when you're dealing with real-world implementations for some digital health interventions. And everyone thinks that as long as you have a good technology platform and good intentions, then you're going to have a successful program and implementation. But the reality of it is you need to integrate with the workflow, and you need to understand how people that are showing up every day, trying to get their jobs done, trying to take care of patients, are going to be able to interact with any technology tools that you develop and implement. We have this iterative process when we design and deploy any digital health solutions. First identify the objectives, try to develop some low fidelity iterations that you can learn from, roll out what's called a minimum viable product, or sometimes we say a minimal useful learning. How are you getting something out of this? Improve and then stabilize. And I think the really critical thing here is the improve portion. Too often we get an MVP out the door and it just sticks due to inertia. And so really important to get the feedback that you get from your providers and staff to roll that back into the program and show them that you're making changes, because otherwise you very rapidly lose trust and engagement. People aren't going to waste their time giving you feedback if you're not actually going to incorporate it. What type of providers and staff do we work to make sure we have included in our programs? So subject matter expert in the clinical area. I'm a urologic oncologist. One of our big programs is in lung transplant. I'm the only urologist that's had something accepted to the International Society of Heart and Lung Transplant, but obviously I don't know anything about lung transplant. So you really need to have a clinician leader in the practice, not just for their clinical expertise, but who's really respected and trusted by their peers and the staff to help drive change management. And then also someone who's willing to commit the time to meet with you and kind of deal with all the issues that any new solution is going to have. I think it's really important to have a clinical operational leader, because at UCSF, a lot of the staff, the nurses, MAs, that are collaborating very closely with the clinicians, technically don't actually report to the clinicians. They have their separate reporting hierarchy through their operational leads. And so having that clinic manager who has a broad understanding of all the aspects of the practice operations and also has a little bit of authority as well. And then making sure you have nurses, MAs, and staff, both individuals and individuals that their peers see as leaders, who can tell you about the real world workflows and also work as kind of change managers with their peers. So I'll give a brief example of a program. This is one of the programs that we've had live at UCSF since 2020, and it's a home spirometry program where patients who have received lung transplants are sent home and were mailed, all the prior ones, a Bluetooth-enabled home spirometer, where they blow into the device, they get data, and it's also paired with a virtual care chat that collects PROs, reminds them to do their spirometry, and kind of adjusts based on just frequency and engagement based on their results. Really want to call out Dr. Hayes here, who's the medical director of the lung transplant program, who has just been such a critical key partner, both in kind of having the use case, but also working very closely with us to actually implement this. And this is an image of the device that was sent to the patients. And again, talk about having stakeholders. Dr. Hayes and his staff showed up at his office on a Saturday and packaged these things up and stuck labels in them and mailed them to patients, right? There's just a certain amount of logistics and blocking and tackling that just needs to happen. We integrated the program with Epic. So when patients have a concerning alert, so their pulmonary function is reported as 10% below their baseline, an alert gets sent to the Epic in-basket, and we develop pools where the practice determines who monitors those alerts and kind of work with them to both refine the thresholds and also work on the workflows. One of the key, philosophies is really we never want to ask a question unless we know how to act on the response. But we also appreciate that sending more alerts to provider in-baskets is going to be an issue. And so really close iteration with the practice to understand the right sensitivity and specificity of those alerts. An example is early on in the program, if patients reported that they were fatigued, that was a red alert. Shocker, it was the middle of the pandemic and everybody was fatigued. And so we were generating 50 red flags a day. And so the providers, Steve came and said, hey guys, maybe this is not the right threshold here. The other piece is, when we talk about having a subject matter expert in your clinician champion, Dr. Hayes single-handedly managed all the alerts for over a year. And his theory was, if we send something to his peers and the rest of his providers that's half-baked, they'll very quickly get disengaged, lose trust, and he'll never gain them back. So he really stuck with it until we felt we had buy-in from the practice. The other piece of workflow integration is getting the data to the providers where they work. So we pull the FEV1 data from the spirometer through the chat back into the EHR, back into Apex, and generate these reports. This would have a patient's name and MRI, which I've blocked out. But the providers in clinic during their routine clinical care can pull this up and see patients' pulmonary function trends, show the patients, engage with them, and really this builds a lot of both trust in the program, but provides something useful to both the providers and the patients. The other thing we did is we compared the results of the home spirometry with in-lab spirometry, because one of the early critiques was that, are these data actually reliable? And so we compared them and we fed this back to the providers. The R-squared was like 0.93 comparing in-lab versus home spirometry. And, this was really compelling data for the practice. And without us kind of imposing any workflow changes, the providers themselves, after seeing these data and interacting with them in clinic, in the real world, said, let's try to streamline this care for our patients. And so in the first 2 years post-transplant, they had a really regimented set of visits that need to happen. And they were all in person, paired with in-lab spirometry. And they took 6 of those during that first 2 years and actually converted them entirely to video visits, paired with the in-home spirometry. And this is one of those things where if I had come to them and said, hey, I'm some urologist, and I'm going to tell you that you don't need to do you don't need to do in-lab spirometry, it would have gotten nowhere. But we developed a program, showed them the data, and then they themselves, as experts in the clinical condition and the workflow, came together as a practice and made this decision. The other, I think, really important piece of engagement with providers is feeding data back to them. At UCSF, we have lots of programs. Oftentimes we have dashboards. I feel like we're always entering data into things, but very infrequently getting data back about our performance or progress of the programs. And so we built a Tableau dashboard, and this is across all of our programs, that shows a lot of detailed metrics, both engagement, new enrollments over time, how long patients have been in the program, how many patients have opted out, how many chats they've completed, how many PROs they've submitted, where they are. And we have a standing meeting once a month where we meet with the clinicians and our clinical partners and show them what's happening, to both kind of reassure them things still running, but also to get feedback from them about what their experience is. The other data that we feed back to the providers is patient response. So at the end of each chat that the patients engage in, they just get a simple 1 to 10 question of how useful they thought it was. So it's a net promoter score. And then a smaller subset of patients are selected to undergo a more detailed questionnaire. And so these are just the results of the net promoter score for our various programs. And again, we feed these back to the providers, and we can see over time, hey, we made this change, this is what happened, or the program's doing great, or maybe we need to really focus on engagement. And then these are the kind of smaller subset of patients who have done the patient experience survey, where they comment if it's something that's useful, if it meets their needs and expectations, if it's easy to remember, user-friendly, et cetera. And really feeding these back to our clinician stakeholders to show how well the program or how poorly the program's doing. And then the final piece that I want to discuss is the in-basket burden, because all of our programs are clinically integrated. They're in real-world use, so they're not pure research programs in a separate system. And so we're sending alerts to the provider in-baskets, and we know across all of our providers, EHR burden and in-basket burden is a major source of burnout. And so we don't want to be major contributors to that. What we built are dashboards that look at the in-basket alerts that come in, and we created a definition of what a quote-unquote relevant alert might be. And the way that we defined a relevant alert is that the person who viewed the alert and marked it as complete, so took responsibility for the alert and cleared it, for that patient, what did they do in the next 48 hours in the chart? What activity did they engage in? If they did nothing, if they just looked at the alert, marked it done, and then nothing happened, that probably wasn't a relevant alert. Alternatively, if they went in and ordered some procedures, some medications, wrote a note, created a new encounter, that potentially was a more useful alert. And again, you can play with what you define as a relevant alert or what should happen, but we take these data back to the provider and say, hey, over the last month, this is what's been going on with the alerts. And then if you, in this dashboard, you can click on a specific time point and say, okay, what happened with this specific message ID? So you saw this alert, you marked it as done, but you also ordered a CT chest bronchoscopy, within the next 24 hours. So that probably told you something of interest. And so really, I think the key points in having, I think, a successful digital health program in the real world with providers and staff using it are making sure you understand workflows, really detailed communication and change management, and making sure you're providing patient value. So we have to understand how people work, understand their existing workflows and try to integrate them as closely, as tightly as possible, and make sure that our program is improving certain aspects of provider efficiency. Certainly there may be places where they're spending more time, but net, we want to hopefully improve efficiency. We have, really close operational partnerships. Steve and I, meet periodically, both to talk about work, but we meet in real life and just, have a coffee or a drink and kind of see how things are going. And these kind of friendships build over time. I know all the, lung transplant NPs and nurses as some urologists. We also have to learn how to speak health system leader language. So it's obviously everything that we do is our goal is to improve patient and provider experience, but we also need to look at these bigger operational metrics, throughput, staff efficiency, potentially billing, so that these programs can continue to be supported out of a business interest, not just out of the goodness of someone's heart. And then making sure that we're actually providing, improving patient experience and making it easier for them to access high quality care. So with that, I will pass off, and I think Gloria is next.
Yeah, thank you so much. Really interesting projects. So let me bring up my slides. So while I'm doing that, I just want to say thank you so much for having me and being able just to hear about the work that you're doing. Please let me know if my slides are not in presentation mode. I believe they are right now. All right, cool. Thank you. So yeah, my name is Gloria, and I'll be representing the FDA today. I work in the Digital Health Center of Excellence as a digital health policy advisor. And I just wanted to give you a very high level of ways that you can collaborate with my team in the Digital Health Center of Excellence, but also just hopefully give you a starting place to really engage with the FDA at large. And I hope some of you are aware that the FDA does do research, and we are interested in collaborating and funding research, and I'll talk a little bit more about that. But first and foremost, we are a government agency that works for you. The American people are very much an important part of our mission. So if you don't get anything else out of this, then just know there's a whole body that is really really out there, really working hard to make sure that there's safe and effective medical products accessible to you. So before I go any further, I just I can imagine that there's such a wide breadth of expertise and research being conducted at UCSF. And so even though I'm going to be talking a lot from the perspective of devices and software, I'd be remiss if I did not acknowledge my amazing sister centers, and all of us are really interested in engaging with you if you are doing work that pertains to our interests and mission. So really encourage you to engage with us, reach out to the different centers to see how your work may really benefit the agency in terms of our different centers. And I'm going to do my best to really point out the times that there are mechanisms that are for FDA large versus very specific to Center for Devices. But oftentimes, there might be a very similar, if not exact, mechanism that I'm going to be talking about in another center, and that may be applicable and very useful to you. So just wanted to start there before I get into my center, the DH COE. And so our mission in the Digital Health Center of Excellence is, really to prepare the FDA for the digital health future, by promoting innovation and ensuring all Americans have timely access to high quality, safe, and effective digital health products. And we do that in a variety of ways. This slide really, begins to touch upon it. But, it really spans the gamut from, doing, interacting with people like you and giving talks like this and making sure people are aware of our existence, to, providing more specific policy guidance documents that really try and provide more specific recommendations to industry on, how to prepare a pre-market application for a device that they're developing, and a lot of things in between. But so much of what we do is involved with engaging and collaborating with a lot of different constituents. And this next slide really touches the surface of how we do that. I have a few more slides, but if we don't get to them, I definitely think this slide really captures on a high level, what are the different mechanisms. And like I said before, just because I'm talking about from the perspective of digital health doesn't mean another center or another group with an FDA doesn't have very similar mechanisms there. So first and foremost, we have the Center of Excellence in Regulatory Science and Innovation. This is called CIRSE. And so this is a mechanism by which FDA engages with researchers in collaborating and funding research projects that are really trying to tackle, big problems and issues that we're seeing, and how we do what we are charged to do. It's a really great program. I actually work with Jean through a CIRSE initiative, and it's been really great way to learn more and really interact through research. So that's one great way I highly recommend if that's something you're interested in looking further into. Collaborative communities are really cool. This is not just a Center for Devices thing. Center for Drugs and Center for Biologics, I know, have them as well. What's really cool about it is it brings people from across focus areas together to tackle a problem. So you might have FDA representation alongside industry and academia, addressing, patient engagement or data or health equity and transparency. So really important problems we work together to tackle or address. It could be, identifying terminology, together, or, creating tools and resources for people. Another great way is network of experts. And so this is a way that, as I'm sure government is limited in the resources and expertise that we have at hand. And so network of experts is a great way that we can engage scientific experts like yourselves and answering questions that we have internally through this mechanism. And with the Digital Health Center of Excellence, we have a network of digital health experts that we can call upon. And then lastly, our inbox. This inbox we utilize for all different types of things, whether you're a developer, a researcher, or just a general public can write to us, email to us, ask us questions. And if we don't have the answer, we can definitely help you to engage with another internal office to identify that. So quickly, I'm just going to point out a couple of things that I have here, and I'll be happy to send these slides to you. If you're interested in regulatory science as a researcher, I highly recommend going to our website, whether that's in the Center for Devices, Center for Drugs, and really identifying, what are the core strategic priorities for each center, and really, analyzing how your research can impact that center and help with our mission. I think that's one of the biggest pitfalls is people not taking the time to really find or really express and communicate, how their research can impact and help our mission, and really sell it, for us to really get excited about the work that you're doing. And not to say that we aren't excited about innovation and technology development, but, our mission is, really providing safe and effective technology and mechanisms and tools that help us do that, is really the kind of research we want to fund. But the two mechanisms, as I talked about, CIRSE, but also the broad agency announcement, that's a research funding mechanism that is FDA wide. More specifically for Center for Devices, there are other things like contracts and grants we can do, and we can work with you, and we can engage to identify if that's an appropriate mechanism for you. Wanted to highlight kind of the big priority areas for the center on this table on the right, but also digital health. We really recently released a spotlight on kind of what our research priorities are here. You can find that online and easily get to it from this slide as well. But would be remiss if I did not call out a great inbox if you are interested in regulatory science with the Center for Devices, and you can reach out to us there. Real quickly, if you are a device developer, I wanted to shout out our Digital Health Policy Navigator, which is an online tool to help you understand whether the software product you're developing is a device that FDA would focus its FDA oversight. And this is really just a starting place. Really feel free to reach out to us in the digital health inbox at digitalhealth@fda.hhs.gov to ask any further questions if going through this tool you have some further questions. Also wanted to just provide for you two some really friendly resources on, FDA at large, our centers and how it works, and all the terminology, all the acronyms. It's a lot, I understand. So I wanted to provide you with those resources to really better understand. And again, other inboxes, all the inboxes that may be helpful to you. So we have our inbox if you have some software particular questions, device determination, if you have questions about whether your hardware or your software product is a device and would be regulated by the FDA. And then on a larger scale, our large customer service inbox, the department is called DICE. They can help you with anything under the sun that is involved with devices and FDA. So I just want to end with, again, our website, our inbox again, because cannot promote our inbox enough. And yeah, I'd be happy to take any questions.
Wonderful. Thank you so much to all the speakers. All the products indeed were very interesting. Okay, so I think there were 2 questions in the chat that Alexis has already helped answer. If anyone has other questions, please start filling up our Q&A box. In the meantime, I'm going to start with one question, which is, how do you find a good stakeholder to engage in a project? I guess like when I first started for example, my PCORI grant, they asked me to go find patients, but like, where do you find these patients? And also like when I started working with the FDA or was interested in working with the FDA, it was really hard to actually find that researcher that I would actually interact with. So how do you find these people? Pick whichever order you guys want to go with.
I can start out just so in the 2 patient partners that we have on our study leadership team were both people that, so one of them was a person that I had met maybe 5 or 6 years ago, even through, he had started coming to like scientific meetings and was there as like the patient rep. And so I just, talked with him at some of those meetings to start the relationship. But then he had also done other PCORI patient engaged projects. And so he was sort of like an experienced patient partner. So that was one. There was a little bit of an organic thing, and then also a little bit that he had done it for other things. And then our other patient partner, she had gotten involved in another like a national group called CDC Million Hearts. And so I had interactions with her from that, and then had invited her to come join our group. And so some of it was, people who were engaged already in other ways, and then bringing them into our project. And then our patients, like I have a little bit less of Jean's challenge in that I have patients. And so some of it is, people that we can lean on either from the cardiac rehab center or people that I see in clinic, although our current group does not include any of my own patients. But it is, just asking people on the ground, like, is there anybody who would be interested in doing this?
I would say, from my perspective, there's two separate trajectories. One is if you already have a clinical interest or a specific condition that you're experienced in or interested in. The other is you start with a technology or approach first, and you're maybe a little bit agnostic to the specific clinical condition. I think if you have a clinical condition that you're interested in, that's pretty easy. You find who at your institution is taking care of those patients and start knocking on doors and kind of meeting with them to see what their clinical and research interests are, what their bandwidth is, and what some of the kind of problems that they see in space. I think if you're starting with an approach and are maybe a little bit more agnostic to the clinical condition, that can be more challenging. What we've been fortunate in is that, our work at the organization is a little bit more known. So we have a lot of inbound interest from providers or informaticists or staff saying like, hey, this would be something that we can work on. The other recommendation I would make is there are a lot of internal conferences and symposia, like, for example, they're upcoming in May. I think it's May. It's the UCSF Health Improvement Symposium. And so there's, hundreds of posters of people showing the work that they're doing and just walking around and seeing, trying to find a similar type of trajectory that you can engage with people. But I think it starts with finding that the clinician who's going to champion the program and knocking on a lot of doors to get there. And then from them saying, okay, who in your practice is the nurse leader that I can meet with? Who's your clinical leader, operational leader? Who's the best? Can you help me find patients to enroll in this program for the first 5 alpha patients?
Okay, that's really helpful. Gloria, I don't know if you want to speak to it more, or I could even.
I think everyone covered it. Networking is really at the key of it.
Yeah, I think for me, at least for engaging with the FDA, I think it was something like a 2-month process where I would hop from person to person to person and eventually find someone, but it definitely took a while. But I think that is how you find a good stakeholder. And then my second question for the group is, what are the most common pitfalls when you're trying to engage with stakeholders? I think everyone had presented kind of general frameworks, but I don't know, what are common mistakes that happen?
I can start this one. I think the one I see the most is people that do not spend enough time really understanding what the mission of the FDA is, and just at large too, in my background as a graduate student, really understanding, what is the purpose of the grant, what is, the purpose behind the mechanism, and really aligning your research to that mechanism. The sooner that you can hit that on the nail from the beginning on what is the impact my research will have on the mission behind the mechanism, the purpose of the mechanism, I think is one of the things I see the most. So the sooner you can do that, you can spend the rest of your grant going into the science and the technology and all of the details there, but really hitting home from the beginning, what is the impact this will have and why should this be funded?
I'll go, and one of the kind of internal biggest pitfalls is not getting data back to your stakeholders. So they don't feel like they're just giving time and not receiving either, progress updates, real-time data, actionable clinical data that they can use in their routine practice. And then also making sure they feel heard, if they have a recommendation for something that is not going well, that needs to be changed, then addressing that in a timely fashion. So if there's something critical, doing it quickly. If it's like a nice to have, letting them know, but being clear on what you're doing, what your roadmap is, when you'll be able to get to things, what you won't be able to get to, so that, kind of everyone's on the same page.
I think jumping off from things that both Anobel and Gloria said, part of it is about like communication and like shared language and sort of learning about the other group too. And so one of the things I most appreciate about one of our patient partners is that he's kind of like helped to orient the other patient advisory board members and other people involved in the project that, this research thing is different than what a lot of patients may expect or have worked on before. And that's not to say that we can't change some of the things that we do to be more accessible or centered around patients. We certainly can. But then there's also things that we will do in research that may seem unusual to patients, and we may not be able to do everything that they're suggesting, whether it's like things related to like research ethics or IRBs, and so there's learning that needs to happen on both sides for us to work together productively.
Yeah, that makes a lot of sense. Okay, I'm gonna jump off of what Alexis was mentioning and kind of get to my next question, which is kind of what's the best strategy for communicating with stakeholders? Like, how often do you do it? I don't know, do you do in-person, Zoom, kind of, I guess Anobel kind of touched on it. And like, how do you keep your stakeholders engaged? Sometimes these projects can be pretty long periods of time. I don't know if there can be kind of difficulties in engagement as well.
Friendliness, communication. I buy beer, I buy Steve beer and coffee, but really knowing that you're in the trenches with them, trying to get these things off the ground. Yes, our providers were getting crushed with in-basket alerts. I added myself to the pool and I was helping clear some of those alerts so they weren't so overwhelmed, being responsive. And so I think, and kind of recognizing that these folks want to solve the clinical problem, right? That's why they're here. They might not care so much about, why the file upload failed and what was going wrong with the protocol or some of the back-end stuff, but they want to solve the clinical problem. So being that bridge between kind of helping them provide better care for their patients will really keep engagement up.
And I think I can both answer this question and the question that Matt posed in the Q&A here. So, communication is key. I would say we meet with people on a sort of regular basis. Like we do try to say, oh, well, we're going to meet quarterly or we're going to meet every other month. But then we don't always meet exactly on that cadence, especially if the needs of the project dictate something else. So like if there's, a little bit of a lull period, we'll maybe skip a meeting, if things are a little bit more active. We may even engage people with, phone calls or emails or Zoom meetings in between group meetings. I think historically we always liked meeting in person, but we've found that we now just meet over Zoom because everybody finds it more convenient. But it's a little bit of both. And then to Matt's question about how do we talk about the scope of what people are doing, I would say in initial conversations, it's more just about getting to know each other and getting to know what people are interested in and what they may want to do. But then once we do start getting rolling and it's clearer what the level of engagement will be, we do basically send them a letter, that's a formal letter saying, thank you for being part of our patient advisory board. This is what we're expecting the patient advisory board will entail, including meetings, blah, 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 frequency, how much we pay you for participating in that patient advisory board, and what the role and expectations are. And so we do actually have like a letter that's like an invitation to the patient advisory board that outlines all of that information. And we're happy, we can supply people with templates or examples of our letters, which we've gotten from other people, including Madeline Faulkner-Madro and other people who have done a lot of patient engagement work.
I think to Matt's question, at least working with the providers, is honestly, you can just be very clear and say, hey, this program is very early and I don't know the problems that we need to fix. So I need your help for storyboarding and journey mapping, versus we have a really clear defined solution that maybe we can only tweak a little bit and we need your help for deployment and implementation. I anticipate needing your help for this many hours a week for this many weeks over this time period, and just really making sure they're bought in. I think, people are happy to engage if they know what they're getting themselves into.
All right. Yeah, this is great. This is really helpful, even for my own staff. I think I'm gonna just end up with one last question, which is, there's obviously, we've mentioned a lot of the upsides of engaging with stakeholders. Presumably there must be some downsides. And I guess, like, what are the challenges when you kind of come across kind of trying to engage stakeholders, and like, how do you kind of overcome them? I guess one example I have in mind is that you just have more people in your project, which could slow things down. And how do you like coordinate everything?
I can definitely. Oh, no, you go ahead, Alex.
Go ahead, Gloria.
I was just going to quickly add, I know Jean has experienced what it's like to get documents approved through FDA. So that's something that's going to come with the territory of working with government. There's going to be approval process. There's going to be different people with different perspectives that want to look at public documents. Definitely something to have in your timetable when you are thinking about publishing things with us. I think there's a lot of great research happening out there. There's a lot of things that you can be investigating and doing, but FDA has a very narrow scope. We are very much focused on, the safety and effectiveness of medical products, and that limits the kind of things that we're interested in funding and looking at. And so being very aware of that before you come and talk to us, I think is super helpful.
Yeah, I do think, it does take time and effort. And in our case, we pay our patients some money too. But I think we feel like it's very worth it in terms of the investment that we make toward making our project stronger, and I think more likely to succeed. So at least for us, it makes sense. And then I will say too, the other hitch is when, a patient partner or somebody suggests something that that's either not what the rest think, or that's in difference of opinion. we do have to like think carefully sometimes about whether that's the right thing to include or not. And so there is always the risk that, somebody's idea doesn't get included. So
one thing
managing
that
those expectations. Yeah.
So that's one thing that we ran into early on is your communication, your messaging has to be clear. And there is a very real possibility that the practice that you're looking to engage is just not ready for it or doesn't want the solution that you're bringing. We had an early experience, this was in 2019, with one of the practices looking at using an automated electronic PRO platform to assess patient symptoms and then try to automatically escalate and triage which ones needed to be addressed first and which ones were maybe less concerning. And the nurses, we honestly ran into a buzzsaw, simultaneously said, there's no way that a computer is ever going to be able to do what we do because we're so highly trained and expert and compassionate, and simultaneously said, you're trying to replace us and we're going to report you to the union. So like very, how do you like hold both of those thoughts that you're unreplaceable, but then you're going to report us to the union? So people have very strong feelings because, they're, especially in healthcare, they're mostly here for excellent reasons. They want to take good care of patients. They think they're doing an excellent job. And you don't want to imply that they're not, even though there's a potentially better approach. And, you can't forget that this is people's livelihood. They've trained their whole lives to do this. They get up in the morning, they come, they do this job to support themselves and support their families and feel fulfilled and kind of deliver good care. And so they may be sensitive to any kind of dramatic changes coming from the outside.
All right. Thank you so much again to the panelists. Also Catherine for helping organize all of this. And thank you to the attendees for attending and as well as asking some really great questions. I think Catherine said that the recording of the seminar is going to be available online. So if you don't want to rewatch it or you want to refer someone else to it, please do so. With that, I think that's it. Thank you everyone for coming. All right. Bye everyone.